Categories of dementia. Dementia due to diseases classified elsewhere. Dementia characterized by marked impairment in two or more cognitive domains relative to that expected given the individual's age and general premorbid level of neurocognitive functioning, whose cause is identified and listed elsewhere in the International Classification of Diseases, ICD-11, is termed as dementia due to diseases classified elsewhere, 6D85. The following categories for dementia associated with other diseases or conditions known to cause dementia are available. 1. Dementia due to Parkinson disease. 2. Dementia due to Huntington disease. 3. Dementia due to exposure to heavy metals and other toxins. 4. Dementia due to human immunodeficiency virus. 5. Dementia due to multiple sclerosis. 6. Dementia due to Prion disease. 7. Dementia due to normal pressure hydrocephalus. 8. Dementia due to injury to the head. 9. Dementia due to pellagra. 10. Dementia due to Down syndrome. 11. Dementia due to other specified diseases classified elsewhere. In all of the above conditions, diagnostic requirements for dementia should meet with the presence of specific disease or condition as demonstrated by neuropsychological test data, neuroimaging data, genetic testing, medical tests, and/or clinical history or family history. 6D85.0 Dementia due to Parkinson disease. Dementia due to Parkinson disease develops among individuals with idiopathic Parkinson disease and is often characterized by impairment in attention, memory, executive and visuospatial functions. Behavioral and psychiatric symptoms such as changes in affect, apathy and hallucinations may also be present. Onset is insidious and typically occurs 1 year or more after the development of Parkinsonian motor symptoms. The course of dementia often follows that of underlying Parkinson's disease. For example, if Parkinson's disease gradually worsens, dementia may gradually worsen. 6D85.1 Dementia due to Huntington disease. Dementia due to Huntington disease occurs as part of a widespread degeneration of the brain due to a trinucleotide repeat expansion in the HTT gene, which is transmitted through autosomal dominance. Onset of symptoms is insidious, typically in the third and fourth decade of life, with gradual and slow progression. Initial symptoms typically include impairments in executive functions with relative sparing of memory, prior to the onset of motor deficits, bradykinesia and chorea, characteristic of Huntington disease. 3. 6D85.2 Dementia due to exposure to heavy metals and other toxins. Lead poisoning is associated with abnormalities on brain imaging, including widespread calcification and increased signal on MRI-T2 weighted images of periventricular white matter, basal ganglia, hypothalamus and pons. Dementia due to aluminium toxicity may demonstrate characteristic paroxysmal high voltage delta E changes. Examination may make evident other features such as peripheral neuropathy in the case of lead, arsenic, or mercury. 1. Dementia is presumed to be attributable to toxic exposure to specific heavy metals, such as aluminium from dialysis water, lead, mercury or manganese, as demonstrated by neuropsychological test data, neuroimaging data, medical tests, and/or clinical history. 2. The characteristic neurocognitive impairments in dementia due to exposure to heavy metals and other toxins depend on the specific heavy metal or toxin that the individual has been exposed to, but can affect any cognitive domain. 3. Onset of symptoms is related to exposure and progression can be rapid, especially with acute exposure. 4. In some cases, symptoms are reversible when exposure is identified and ceases. 4. 6085.3 Dementia due to human immunodeficiency virus. Dementia due to HIV may develop during the course of confirmed HIV disease, in the absence of a concurrent illness or condition other than HIV infection that could explain the clinical features. Although a variety of patterns of neurocognitive deficits are possible depending on where the HIV pathogenic processes have occurred, typically deficits follow a subcortical pattern with impairments in executive function, processing speed, attention, and learning new information. The course of dementia due to human immunodeficiency virus varies and may involve gradual decline in functioning, improvement or resolution of symptoms, or fluctuation in symptoms over time. Rapid decline in neurocognitive functioning is rare with the advent of antiretroviral medications. 6085.4 Dementia due to multiple sclerosis. Cognitive symptoms are not primarily due to associated physiological or functional effects of the underlying disease, for example, fatigue, motoric limitations. Onset of symptoms is often insidious but may progress in a stepwise fashion in accordance with the underlying disease course. Neurocognitive impairments vary according to the location of demyelination but typically include deficits in processing speed, memory, attention, and aspects of executive functioning. 6085.5 Dementia due to Prion disease. Dementia due to Prion disease is caused by a group of spongiform encephalopathies resulting from abnormal prion protein accumulation in the brain. These can be sporadic, genetic, caused by mutations in the prion protein gene, or transmissible, acquired from an infected individual. Onset is insidious and there is a rapid progression of symptoms and impairment often characterized by neurocognitive deficits, ataxia, and motor symptoms, for example, myoclonus, chorea, or dystonia. Diagnosis is typically made on the basis of clinical presentation, brain imaging studies, presence of characteristic proteins in spinal fluid, EEG, and/or genetic testing. 6085.6 Dementia due to normal pressure hydrocephalus. Dementia due to normal pressure hydrocephalus results from excess accumulation of cerebrospinal fluid in the brain as a result of idiopathic, non-obstructive causes but can also be secondary to hemorrhage, infection or inflammation. Progression is gradual but intervention, for example, shunt, may result in improvement of symptoms, especially if administered earlier in the course of the condition. Typically, neurocognitive impairments include reduced processing speed and deficits in executive functioning and attention. These symptoms are also typically accompanied by gait abnormalities and urinary incontinence. Brain imaging to reveal ventricular volume and characterize brain displacement is often necessary to confirm the diagnosis. 6085.7 Dementia due to injury to the head. Dementia due to injury to the head is caused by damage inflicted on the tissues of the brain as the direct or indirect result of an external force. Trauma to the brain is known to have resulted in loss of consciousness, amnesia, disorientation and confusion, and/or neurological signs. The symptoms characteristic of dementia due to injury to the head arise immediately following the trauma or after the individual gains consciousness and must include persistent cognitive impairments following any recovery of initial cognitive impairment that may be seen in the immediate post-injury period. Neurocognitive deficits vary depending on the specific brain areas affected and the severity of the injury but can include impairments in attention, memory, executive functioning, personality, processing speed, social cognition, and language abilities. 6085.8 Dementia due to pellagra. Dementia due to pellagra is caused by persistent lack of vitamin B3, niacin, or tryptophan either in the diet or due to poor absorption in the gastrointestinal tract due to disease, for example, Crohn's disease, or due to the effects of some medications, for example, isoniazid. Core signs of pellagra include dermatological changes, sensitivity to sunlight, lesions, alopecia, and edema, and diarrhea. With prolonged nutritional deficiency, neurocognitive symptoms that include aggression, motor disturbances, ataxia and restlessness, confusion, and weakness may be observed. Treatment with nutritional supplementation, for example, niacin, typically results in reversal of symptoms. 6D85.9 Dementia due to Down syndrome. Dementia due to Down syndrome is a neurodegenerative disorder related to the impact of abnormal increased production and accumulation of amyloid precursor protein, APP, leading to formation of beta-amyloid plaques and tau tangles. AP gene expression is increased due to its location on chromosome 21, which is abnormally triplicated in Down syndrome. Cognitive deficits and neuropathological features are similar to those observed in Alzheimer's disease. Onset is typically after the fourth decade of life with a gradual decline in functioning, and may impact 50% or more of individuals with Down syndrome. Thanks for watching. Please like and subscribe.